Good morning, good afternoon, and welcome everyone to today's webinar, Religion as a Social Determinant of Health in Older Adults, exploring religious attendance, importance, and affiliation as predictors of adult mortality. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are delighted you could join us. Some housekeeping instructions off the top. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio or visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit text questions for our presenter by typing your questions into the questions pane of that same control panel. You can send in your questions at any time. We will collect these and hope to include them during a Q&A session at the end of today's presentation. I'd like to draw your attention to Spiritual Care Week. We're offering webinars virtually every day the week of October 23rd. You can screenshot the QR code or type in the URL, and you'll see a listing for webinars for every day. And hope you can join us. With that, I'd like to introduce Sarah McAvoy, co-convener of Transforming Chaplaincy's Elder Care Spiritual Care Research Network. Sarah?
Thank you, Andrew. Thank you so much. And thank you all to everyone joining us for this special webinar with Dr. Ellen Eidler. As Andrew mentioned, my name is Sarah, and I'm one of the co-conveners of the Elder Care Research Network, along with Catherine Lyons. And Catherine and I were privileged to see Dr. Eidler make a similar presentation to this at the International Conference on Spirituality and Aging. And we're just thrilled that she agreed to make this presentation for our group. Dr. Eidler is the Samuel Candler Dobbs Professor of Sociology and Director of Emory's Religion and Public Health Collaborative, with additional Emory appointments at the Rollins School of Public Health, the Center for Ethics, and the Graduate Division of Religion. She earned her PhD from Yale University and held a fellowship at Union Theological Seminary in New York. Dr. Eidler is a fellow of the Gerontological Society of America. She served as chair of the American Sociological Association section on aging and the life course, and received its 2021 Matilda White Riley Distinguished Scholar Award. She studies the influence of attitudes, beliefs, and social connection on health, including the effect of self-ratings of health on mortality and disability, and the impact of religious participation on health. Dr. Eidler, welcome, and thank you so much for being with us today. I look forward to learning more from your important work. Thank you.
Well, thank you for having me. And it looks like I'm the presenter, so if I can share my screen, you can all give me a thumbs up to see whether it's showing or not. So, am I good?
Looks great, Ellen.
Great, thank you. Okay, always reassuring to know that everybody else can see it too. So yes, that was a very nice introduction, and thank you. I'm coming to you from Emory University in Atlanta, Georgia, which is a wonderful place for interdisciplinary research, and that is what this really is. So I'd like to start off by talking about what the social determinants of health are for those of you who may not be familiar with that terminology. And I know that some of you are very familiar with it, so I hope you'll have patience with me. But the idea of the social determinants of health really does have a very strong connection to what I see as the wheat field and the life course. And you can think about it as the parable of the sower from Matthew 13. The social determinants of health are kind of like the circumstances into which we are born, or the circumstances into which the seeds of the sower were sown. So as you'll remember from the parable, the seeds of the sower, some of them fell onto rocks, and they were probably eaten by birds or animals. And some of the seeds fell onto dry ground and failed to germinate. And other seeds fell onto good soil, and they had rain and they had sunshine, and they germinated and they sprung up. And so that little bit of the start of the parable of the sower tells us that we are born into circumstances that we do not choose. And this idea of the social determinants of health is that many of those circumstances are unequal. They are advantaged or disadvantaged in various ways. So where the seeds are cast gives us an idea about those unequal circumstances. But think about it over the whole life course, because it really does extend on. Some of those seeds that fell onto the good soil sprung up very quickly and grew tall. Their roots grew long into the soil, and if there was a dry spell, their roots were long enough to continue to get water for the plant. And those plants grew bigger, and they got bigger leaves, and they towered over some of the other plants and provided shade for them, which may have kept them from getting the sun and also the water that they needed. So there is a continuing impact of unequal circumstances of birth over the entire life course. And I would say this is the paradigm in public health today, that the social determinants of health are the biggest and most important determinants of population health. In 2007, there was a World Health Organization commission on the social determinants of health led by Sir Michael Marmot, a British epidemiologist and physician. They did a big report, and this is the definition of the social determinants of health from that report. The circumstances in which people are born, grow up, live, work, and age, and the systems put in place to deal with illness. These circumstances are in turn shaped by a wider set of forces: economics, social policies, and politics. So that's a great definition, and I love the life course dimension of it. But in that entire big book, which is really big, and I have a copy over on my shelf, there's no mention of religion at all. And for many of us at Emory, it seemed as if religious communities really ought to be considered as among those social determinants of health into which people are born. Those circumstances, either there or are not there, for billions of people around the world. And those religious institutions are among the wider set of forces. So it maps onto the definition in a really important way. So I'd like to talk about some current research that derives from a study that was in the Journal of the American Medical Association last July 2022, that constituted a very wide net of research on religion and health, and I think places it squarely among the social determinants. So that study was led by researchers at the Harvard T.H. Chan School of Public Health. What they wanted to do was a systematic review, meaning a comprehensive systematic review of all of the research on religion, spirituality, and health. They had two different sections for it, and they used a Delphi panel approach. If some of you are not familiar with that, it's an assemblage of experts in the field who judge the quality of the studies. So the leaders of the group at Harvard assembled all these studies, and then the Delphi panels were to rate the quality of these studies according to a number of different criteria. So I was a member of the Delphi panel for one of the two groups of studies, which was the health outcomes study. And so this paper got a lot of notice, as you can see from the press release from Harvard, and it was published, like I said, in July 2022 in JAMA. So the researchers, using the quality assessments of the Delphi panels, looked at a whole range of possible health outcomes. You can see the categories here, from all-cause mortality to physical health, health behaviors, mental health, and quality of life. And a range of different measures of religion and spirituality. And so with a matchup of those two things, a measure of spirituality or religion and a measure of health, the strongest evidence across all the studies was for the predictive ability of religious attendance as a protective factor against all-cause mortality. And of the most of the studies in that category were judged to be of at least good, if not excellent quality. And there were 31 studies or 32 studies in that group, and all but one of them showed a significant protective effect of attendance at religious services on mortality. So one of the studies that was included was one that we did here at Emory, and used data from the Health and Retirement Study. Since this is a research network, I thought I'd just say a little bit about the wonderful data set that we used, and then I'll show you the findings. The Health and Retirement Study is a public use data set available from the University of Michigan. It's been going on since 1992, and every other year participants in the HRS are interviewed. It is a nationally representative sample of adults who do not live in institutions. The interviews take place in the home, and African American and Hispanic households are oversampled, so we get better estimates for those groups. It's a really great data set, both to study economic well-being as well as health. The unfolding bracket technique that they developed for gathering economic data is amazing, and they have really comprehensive information on income and wealth and financial assets of all kinds. They have really good response rates. And so we use the data beginning in 2004, because prior to that, they hadn't been asking any questions on religious attendance or the importance of religion. But in 2004, they started asking about frequency of religious attendance and also how important religion was. And additionally, the religious affiliation of the respondent. So we had 18,000 some people in our study, all of them age 50 and older. And the frequencies are very close to what you would expect from national samples. So there are religious affiliation breakdowns. About 50% said that they attended weekly or more often. 65% said that religion was very important to them. Yeah, I don't need to go through every one of those, but I can show you some findings. I know tables like this are hard to look at, but I'll just pick out a few things. So this is a summary of the findings from all of the models. They're listed across the top, but only showing the results for the religion variable. So at the top we have frequency of religious participation, and these are Cox proportional hazard models for all-cause mortality. And so that means that not only is the mortality of the person assessed, but also the length of time of survival during the follow-up period. The follow-up period was for 10 years. So in the first model here, we have only the 3 religion variables, and then we add in age and gender and marital status. And in the third one, we add in socioeconomic status. And in the fourth one, we add in health status. Health status is an important confounder because if people are ill, that could change their ability to attend religious services. So you'd have a reverse causality situation. But so in some ways, I would say that this model is the best one to look at. And as you can see, for religious participation, a hazard ratio of 0.60 is telling us that people who frequently attended religious services were 40%, 1 minus 0.6, 40% less likely to have died over the follow-up period. People who attended regularly but not frequently had a 27% lower likelihood of mortality, and those who occasionally attended, not even that often, had a 15% reduction in mortality. So there's what epidemiologists would call a dose-response relationship. I'm going to get my pointer option up here because it keeps fading out on me. Well, it's not working. Sorry, it's not working in this. Sorry for that little technical glitch. Okay, so we have a dose-response relationship. When we added in health behaviors like smoking and alcohol use and exercise, you can see that the occasional attenders aren't significant anymore, but there are significant protective effects here. When we added in social ties, there also were still significant protective effects. So that's the story for religious attendance. It goes along very much with the overall systematic review results that attendance is a protective factor. But we had two other religion variables, and just to look back at the health status column here, which is the best one without confounders, you can see that there are no significant effects of religious affiliation. So it didn't matter what religious group people belong to, and all of these are being compared to people with no religion. There are no significant differences between religious affiliations, but there is a significant effect for the religion is very important to me variable. And as you can see, it is a number that's above 1, meaning that it's the opposite of a protective effect. It's actually a risk. So it does seem as if people who were who said religion was very important to them were 4% more likely to have died by the end of the follow-up period than people who said that religion was not important to them. So this I interpret as a sort of indication of the need for meaning and comfort in life, and that religious importance during times of stress and crises can be very enhanced. So just to sum up a little bit, their evidence is really strong. I mean, the JAMA study was pretty incontrovertible evidence since they reviewed all studies, and then they had so many people involved in it and 2 years of work. So it was a very big project, and I don't think anyone will have to do that again, not for a long time anyway. And so the strongest effect that they found was this association protective effect of religious participation, in other words, the social dimension of religiousness, and all-cause mortality among all of the different kinds of health outcomes. The measures of private religiousness in our study and in the big systematic review also shows either that there are no effects at all, or that in fact in some cases there can be a kind of increased risk, although I don't think of it as causal, so I don't really want to use that word. There are lots of known pathways for why religious attendance would be protective against mortality. People who attend religious services more often are much less likely to be smokers. They are less likely to drink to excess. They go to the doctor and get health screenings. There's lots of studies that show that the social control of behavior and through direct known health behavior risk factors is improved by religious attendance, or it just is associated with it. So you need to control for those things, but also social support and networks are very important. People who belong to religious congregations have larger social networks. They are more likely to be married and to stay married. They are more likely to socialize with others. And the opportunity to offer support to others as well as to receive social support is a really important dimension and an opportunity given to people who belong to religious organizations. And then social capital, the bonding and bridging to other social and community institutions, just tells us that people who belong to religious congregations have more engagement in their communities at large and a wider reach in their communities, and all of those things are protective of health. So religion is a life course influence, and as I said earlier, that it is something that is a part of the circumstances of our birth, that we do not choose, that we do not choose the presence or the absence of it. It is something that can be changed earlier or later in life when people make choices about those things. But the influence from childhood is a really important factor. And then it has its biggest impact on health in middle and old age, as you can see from some of what those mediating pathways are. So there is a great deal of research on religion and health. A lot of it, I'm giving you a few suggestions for readings down at the bottom here. There is a lot of research. A lot of it is very good research. And if you really want to get the most recent review of it, I would suggest you get the JAMA article from July 2022. So I wanted to speak about the health outcomes part of the the systematic review. But the other panel, the other group, was for trying to understand the impact of religion on serious illness. And so here we are back at the same systematic review slide again. But this was led by Tracy Balboni, who was the lead author of the whole study, and was interested in a range of outcomes that include, as you can see here, that some of the findings were about the role of spirituality in serious illness and how important it was to people in their top group of studies. And these are ordered in terms of the strength of evidence, that studies that had a good quality of them, in those 71 to 99% of seriously ill patients viewed spirituality as important when they were asked about it. And that measures of spirituality and spiritual engagement were associated with better measures of quality of life in serious illness. Spiritual needs are very common, and when they are not met, that can arise in worse quality of health outcomes. That spiritual care is desired by people and that it can play a role in medical decision making. All of these are very important aspects of the work of chaplains. So I think for this network, this second panel, which actually is talked about first in the study, it would be of a special interest, I think, for all of you professionally who are engaged in this work. So the importance of meaning and comfort in religion, or excuse me, meaning and comfort that religion and spirituality provide for people who are in late life or with disabilities or encountering serious illnesses. Religious engagement can provide a really important source of reduction of social isolation and a feeling of participation. This is a photo from a little church that I know well, and this is a arriving group of people from a group home of seriously disabled older adults. This is the only time that these members of this group home go out. So the opportunity for people in the congregation to welcome them, as you can see, opening the doors for them and helping them get in, is a really important moment in the week for them, when they can hear music and see little children running around and have coffee and donuts, and you can imagine the importance of this. It does take a lot of people to help them do that, but religious congregations are often very good at outreach and trying to reach people who have difficulties with transportation and access. This little church, which is in New Jersey, has a healing service once a month, and people come up after the service and their prayers and songs, and the provision of meaning and comfort is certainly a central part of what this congregation does. And I'm showing you this. This is a communion visitation kit. This was my father's. My father was a Presbyterian minister, so I was the little daughter of a Presbyterian minister, and I had a very deep fascination with Daddy's little tea set, which usually was in his office at the church, but sometimes after he used it, he would bring it home and my mother would wash it, and so I was able to look at it up close and was not allowed to touch anything, but it seemed incredibly significant to me. And it was very significant to the people who received these visits. So in the Reformed tradition, communion is given to people who are unable to attend services only on the days when communion was celebrated in the worship service by the congregation as a whole. And so on those afternoons, my dad would go out and visit the homes of people who were ill and take communion to them. And so it was a very much a way of bringing them into the fold of the congregation, including them in the larger life of that congregation, and making sure that they did not feel isolated and alone. And then continuing with the idea of meaning and comfort, I was able to do, this is an old study, but we were able to do some really interesting analyses of data from the Yale Health and Aging Project over the years from 1982 to 1988. It was a large sample, almost 3,000 people, and about over 1,000 of them had died between 1982 and 1988. And we were able to, because we knew their dates of death, we were able to test an idea that had been in a few studies had been done about it at that point, that showed that older people were often less likely to die right before a specific event, and most of those had been about birthdays rather than religious holidays. There were only 1 or 2 studies about religious holidays before this. So we were interested in whether there would be a difference in the frequency of deaths occurring before religious holidays compared with after religious holidays. So the hypotheses from the literature were that people in advanced old age, near the end of their lives, would exert a sort of will to live a little longer in order to celebrate a religious holiday with their family and loved ones, and more likely than to die afterwards. So in the New Haven sample, we had a large enough number of Jewish respondents that we could actually think about Jewish holidays and Christian holidays, and Christians for Jewish holidays and Jews for Christian holidays. So we were able to do the sort of testing of the opposite hypotheses. And what we found was fairly strong findings. There were fewer deaths before, if we look over at this side here, every time I touch my thing, it goes away. Okay, so these are the numbers of deaths that occurred. In the 30 days before Easter and Christmas, there were 58 deaths in total. And in the 30 days after, there were 80. And that's a statistically significant difference. It was true for males and females, for more and less observant Christians. And pretty much as you go all the way down here, I think there was less of an effect for Black Protestants, but also a much smaller number, making it harder to get statistical significance. And for Jewish respondents, there were no statistically significant differences for deaths before and after with the Christian holidays. For the Jewish holidays, it was the findings were a little bit different. So among males for Passover, there were 5 before and 11 after. Rosh Hashanah, not a statistically significant difference. Yom Kippur, yes. And so for all the Jewish holidays, 14 deaths before and 26 after, that was a very statistically significant difference. For more observant Jews, there was statistically significant differences for all the holidays and for Yom Kippur and Passover. And if you look down here, there are no differences for Christians around the Jewish holidays as expected. But if you look at this line, you'll see that there are more deaths for women before the holidays than there are after. And that was a very surprising and shocking finding to me. So if you add up all Jewish respondents, you actually get no differences before and after the holidays. But because I've presented these findings a lot of times over the years. This is an old study from a long time ago, but I've had any number of audience members come up to me and tell me afterwards that they thought that this was perfectly understandable, and that very elderly Jewish women who were near the end of their life anyway, this isn't like a mortality study really, it's only a difference of a few days or weeks in the timing of death, a difference. So that explanation of women's desire to not, and the extra work that Jewish women have to do before the holiday has always been given as an explanation. We just talked about this in my class last week, and I had a number of people also tell me that that this makes perfect sense to them. So among more observant Jews, and those are also mapping onto the males, there were fewer deaths before the holiday than there were after. but a big difference by gender. So let me finish by talking about the age of secularization. That old study and these new ones have been done in a period when there's less and less engagement with religion over time. And this is a worldwide phenomenon. The Pew Research Center finds that younger adults are less religious than older adults in many countries. So you can see a number of different dimensions of religiousness in terms of identifying with any religious group. 41 countries, in 41 countries, younger people are less religious than older people. Older people are the blue. Consider religion very important in their lives. In 46 countries, younger people are less religious. In attending worship, in 53 countries, younger people are less religious. And in terms of daily prayer, 71 countries show that younger people are less religious than older people. So there's very few, very tiny numbers where older people are less religious than younger people. And it does seem to be the behavioral participation, attending worship and praying daily that really mark out the biggest differences between younger and older people. And so this worldwide phenomenon, which really kind of started in Western Europe, has been something that social scientists have talked about for a long time, as to whether the United States was going to follow the European countries in their move to, real disengagement with religion. There was a lot of arguments about it because in the United States there were always higher, during the 1980s and 90s and 2000s, there were always higher proportions of people attending religious services more regularly and affiliating with a religious group more often. So people argued in social science circles about whether there was an American exceptionalism to secularization. Some people said that, the US was the fatal anomaly that disproved the entire theory of secularization. This book by Peter Berger and Grace Davies really made that argument. But that was a while ago, and now we have more data. So a pretty convincing article was published in the American Journal of Sociology in 2016 by David Vose and Mark Chaves. And they used data from the General Social Survey, which is the National Opinion Research Center's data from the University of Chicago. And they had a really long time series from 1974 to 2014. And what they did was construct moving averages of what the responses to that survey were for whether people had a strong or somewhat strong religious affiliation. So if people said they were Protestant, Catholic, Jewish, other, or none, then they asked, is that a strong or somewhat strong religious affiliation? And it doesn't matter exactly which one it was, but just the strength of it was what's being mapped here. And then they organized those responses over these years for which they had data by the birth cohort of the respondents. So people who were born before 1915, so people who were born in the early part of the 20th century or even in the 19th century, as you can see, over 60%, trending up to 70% of people said that they had a strong or somewhat strong religious affiliation. People who were born from 1915 to 1924 are lower. You can see the gap here. But trending upward over time, but going from the mid 50s to the mid 60s. And then those born in 1925 to 1934 is the green line here. Again, you can see there's a gap, and trending from the 50s to the low 60s. I don't need to go through every one of these lines with you. You can see there's a gap. So for every successive birth cohort, there are fewer and fewer people saying that they have a strong or somewhat strong religious affiliation. So here are our baby boomers in the red and blue here. The later wave baby boomers here are less than 50%, even in the most recent period. from 30%. And then our Gen X and Y and millennials are all much lower. So as you can see, with every year, there's a big gap, and the trend is downwards. So it's a generational shift rather than an individual change, because these are being mapped by generations. So that was what strong or somewhat strong religious affiliation looks like. Another question on the survey was, do you know that God exists? And again, for our very early birth cohorts here, over 70% said yes, they knew that God existed. But again, although there's some overlapping lines here for the mid 20th century birth cohorts, by the time you get to the 1975 and 1985 birth cohorts, you can see that the numbers go down considerably. And the number of people who say that they know that God exists. So I was interested in doing an analysis of the health and retirement study to ask this question. The data that we would have would be a little bit later, and it was a nationally representative cohort again. So and we had some different measures of religiousness. So this is what my portrayal of the data looks like. So using the question about frequency of religious attendance, there we grouped the birth cohorts for those who were born before 1915. And so these are people who are really quite old in 2004. There were 563 people in this group in 2004, but by 2016, at the end of the data series, there were only 9 people left. So these are very elderly and perhaps frail people. But beginning in 1915, birth cohorts, and then all the way through, you can see that there's a generational drop in the frequency of attending religious services, weekly or more often. And so the survey years are built into the cohort. So it's the cohorts over time with repeated measures. So you wouldn't expect there to be a big difference from year to year of the survey. It's the generational difference, I think, that is really notable from this graph. That was the percent attending religious services weekly or more often. This is the percent of people finding religion very important. And note, there's not really any drop off here. The before 1915 group is very high, and it doesn't drop off as quickly, but you can see that there is definitely a trend downward for these cohorts. There aren't as many survey years with this question, so they look a little different, but it's the same sort of generational shift. And then they also asked a question about, do you have good friends in your congregation? And again, there is a downward trend in the proportion of people saying that they have good friends in their congregation. And keep in mind, these are older people who are more religiously engaged than younger people are to begin with. So one thing you can say about the health and retirement study is that they really don't have a lot of measures of religious involvement. For example, there's no question about how spiritual a person are you, and it's very possible that many of the other dimensions of religiousness and spirituality that are not measured could better characterize the younger age strata. So the fact that there is less attendance and less importance of religion or knowing God exists, all of those things might be less likely to be endorsed by younger age groups, but that could be other unasked questions that would have been endorsed. So since we know that religious attendance is associated with mortality, that means that people who have been frequent religious attenders all their lives have a survival advantage. And that means that by the time of reaching very old age, there are a lot of selection processes that have also happened. So the selection processes mean that older people are more likely to be religious, and that sort of increases this idea that it's older people who are more religious than younger people, partly through mortality selection. And then I mentioned about they're very strong religious affiliation of the people in that early group who have seen a lot of social change since they were born before 1915. And then there was the pandemic, which changed everything in terms of secularization and disengagement from religious communities. And so there's so much to say about this, but moving religious services to live streaming was a way of keeping connections in religious congregations, but that meant that probably a lot of older people were unable to do it. This lady in the picture obviously was able to do it, or at least knew how to get on Zoom, but for many older people, especially more socially isolated people without grandchildren or children to help them get linked up, could have really, or not even having the devices in the first place, really kind of shut out the people who would have been the most likely to want to continue religious services. And so it seems as if, this restriction and precisely the people who were the most likely to still be participating would be the people who were most likely to be left out. So there's an unfortunate kind of confluence of who the most vulnerable people were during the pandemic, which was older people, most likely to have very serious consequences of contracting COVID-19. Those were exactly the people for whom the loss of these other social ties was pronounced. And it's of all of the different dimensions of religion, it's the gathering, it's the congregating dimension of religiousness, which has been shown to be the most protective in health research. And that's exactly the most dangerous thing. Mass gatherings were the most dangerous thing during the COVID-19 pandemic. So there's just so much irony about age and COVID and religion, and all of it, well, complicated. But I like to think of I don't know how many of you have ever come across the term, the second demographic transition, but there are people who've thought about social change and it linked the secularization process, especially in Western Europe, to the decline in other kinds of social institutions, especially marriage, in the US and in Western Europe. And the shift to societies in which fertility rates are much lower, in which gender equality is much stronger, and in which the authority of these traditional institutions has declined, is sometimes this, Ron Lesteg calls it depillarization. But, I think it's good to place the idea of the secularization of religiousness in the context of the decline in these other kinds of traditional institutions. And so, when people say, oh, well, what is the possibility for other kinds of social institutions arising to take the place of marriage and religion. And particularly with religion, I've certainly thought about that question an awful lot. It doesn't seem to me as if there's an obvious replacement, because religious congregations have really provided a lot of outreach for older members, accommodating them in ways that other institutions do not. And religious congregations are, unusual places in so many respects, where people have the opportunity to experience live music, to even sing themselves, to be in an intergenerational community where young children and very elderly people are all there on an equal footing and with an equal sense of belonging, and the long social network ties that can unfold over time, and the resources that religious congregations provide for people in times of crisis. All of those things there isn't an obvious replacement as far as I'm concerned. But I would love to hear your thoughts on it. So I can end my sharing of slides and engage with you. Thank you very much for inviting me.
And thank you very much, Ellen, for your presentation. I've had the pleasure of hearing your work a few times, and each time I get something new about religion and religious participation and secular trends. The focus on religion as a social determinant of health. I teach gerontology, and the number of textbooks who do not mention this is startling to me. So hearing your work helps to spotlight such a crucial dimension of human meaning making. We do have a few questions to run by you. I think the first is might be a helpful place to start. Somebody was asking about how did the study define religious participation, religious attendance?
Which one?
Let us, how about, they didn't specify, how about the health and retirement study?
Well, the health and retirement study had these 3 questions. That's all they have. So frequency of religious attendance, and the categories were more than once a week, weekly, monthly. Well, they actually had how many times per month. And I think there were 5 categories in the original question, and we pushed them down to 4. So frequency of religious attendance in the HRS, how important is religion to you, and 3 categories of very important, somewhat important, not important at all. And then the last one is religious affiliation. The religious affiliation question in the HRS, they did an amazing job of differentiating very, a large number of denominations and sects and groups. So you can't, they do a masking so that if you're using the public use data, you can't identify people, because very small groups in a big data set like that could potentially identify someone. So unless you get the restricted data, you can't know about all of the tiny small religious groups, but somebody spent a lot of effort into coding all of the religious affiliations. So those are the 3 questions. As I hope that's the right group that they wanted to know about.
Sure. Can you say more about the variable religion as important to the participant, and the finding that this group had a 4% increase in mortality rate, and what you think that this signifies?
Oh, I think that's a really interesting finding, and that is not the only time I've ever seen that. We had data from the Yale Health and Aging Project, and a similar question. I think at YHAP, the question was, how much strength and comfort do you get from religion? So we didn't have an importance of religion, but they did the same kind of thing. So how much strength and comfort do you get from religion? And the answers were a great deal, somewhat, or a little bit, something like that, and then none at all. And so like 80% of people said they got a great deal of strength and comfort from religion in the Yale Health and Aging Project. But that was always associated with, shall we say, worse outcomes. And it seemed, kind of, I think that question actually kind of clarifies it, because needing a great deal of strength and comfort from religion indicates that a person is that they are seeking consolation and support from their religious beliefs. So it indicates a level of need for it in the first place. So it does seem to be associated with health crises, but it could be other kinds of crises as well. Yale Project was very old people.
That's really interesting. So it may indicate some level of vulnerability.
Absolutely.
To some respect, whereas religious attendance is more of a sign of some kind of maybe strength or resilience.
Yes, and so I mentioned a little bit about reverse causality and how important it is to adjust for health status if you're going to study a social participation variable, because poor health could prevent someone from attending, despite what, all the outreach of congregations to enable people who have limited transportation, limited physical ability to attend services. It, you know, and in a lot of studies I've looked at, it doesn't seem to make that much of a difference. So this reverse causality argument, I've not seen a lot of support for it. Honestly, it seems, and I've seen also that, you know, people with poor health and disabilities may be more likely to attend religious services than people who are relatively healthier. So it's
Yeah.
not preventive at all, but it does speak to the idea of seeking the solace of a community, and you know, and you said it as a sign of resilience, but it's a form of coping, you could say, that it can be supported by the community.
Yeah, maybe the mortality rates would be even higher if they didn't see the importance of religion. Yeah. So another question that came over is about related to the aging and secularization of America and the trend over time to decrease the decreasing participation in religion. Any thoughts on the impact this could be having on health and illness and mortality?
Well, it seems as if one consistently protective factor is becoming less and less widely available. So if you studied the protective effect of attendance on mortality among people who were elderly in the 1980s, and you studied it today, you might find similar effects, that those who attended most frequently had lower mortality. But the number of people attending more frequently would be lower. So the protective effect would be diminished in terms of population health. So I think that's what you're asking about, like the impact of this social determinant of health on population health is, I can only say it seems like it must be diminishing. I don't know how you would really study that other than with being able to compare, you know, data collected in earlier times with data collected later.
Yeah, that makes a lot of sense. Sarah, do you want to ask your question?
Yes, I was thinking about, you know, bringing it to the context of many of the chaplains in our group who conduct weekly worship services within their healthcare communities. And I'm wondering about the difference of attending outside in the community, as you say, in an intergenerational setting, and the difference between that and the nursing home service, and what that might do to the protective factor, or how we as chaplains can maybe modify those services to bring in some of those elements that might create a more protective, you know, use of religion, if that makes sense. I'm having trouble framing the question, but
No, I love that question. So I'm remembering back from the Yale Health and Aging study. So they sampled respondents in the community, but if they did move to a nursing home, they would continue to keep them in the study and interview them in the nursing home. And I remembered finding that attendance was very high among the people in the nursing home because it was so easy for them to attend, and it was an important aspect of the week, as you say. So, I mean, some elements could be very similar in that music and liturgy and the rituals of the service could all be, you know, very much a part of the elements of a regular worship service in the community. But you're right, there probably won't be any little kids there. And the opportunity to see people that you don't see all the time. So I don't know, I mean, in a very large institution, it might be that some people don't see each other frequently and they could in that setting, but I think that's one of the important elements of the social dimensions of congregations, is that they bring people together with weak and strong ties. And, you know, there's always people there you don't know, or somebody walks in and you never saw them before, then you go and say, welcome, and we hope you come back.
Right.
Yeah, so there wouldn't be that much of an opportunity for meeting new people, but it could certainly be a way for new residents to meet people when they were there. It seems like making special inclusions of new residents would be a very important part of it. And maybe, maybe you could get some little kids to come in and sing.
Something for us to think about as chaplains, I think. The other thing that I was thinking about, we've done some education on how to conduct worship within the dementia space and how to make worship services accessible for people with dementia. And I do wonder about the same protective element there, when there isn't perhaps always that cognitive understanding that I'm at worship, or that, so I wonder if there have been any studies in that area that you're
Well,
aware of.
in the book that we did on religion as a social determinant of health, one of the first part of that book was all about religious practices, and one of them was was about music and worship, and it was written by a faculty from Candler, one of the musicians there, and he chose to write about Alzheimer's disease and the importance of the connection of music. And I'm sure you've seen the Music and Memory film, and the connections that people have even when they've lost a lot of their day-to-day cognitive facilities. That connection of music is so important. And I forgot, I have this beautiful slide of a rabbi singing to a very obviously very confused older person, but she's just drinking in every bit of it. I should have put that slide in. It's so beautiful, and anyway, I could have. But it was an article, it was in the New York Times a long time ago, and I always just was transported by that picture. But the rabbi's advice was keep it short and a lot of music. So yeah, I mean, I do think that music seems like a real key dimension. So yeah, we did have a little chapter. It wasn't research at all. It was his personal experiences of the connection that some older people have when they really aren't connecting in any other way. They know the words and they can sing them to the hymns.
Yeah.
They're familiar enough that they still have a way of really belonging to the group in that way.
Yeah. My final reflection on your talk, and once again, thank you so much, was the comment you made about the importance of the opportunity to offer social support and to receive social support. And that really struck me within the context of the services that we hold in the nursing home, offering residents explicit opportunities to offer support to one another, even in the context of that weekly worship service, whether that's, just the socialization or actually participating. Residents who can play the organ for the service, or, those types of things where there's more interaction than just receiving a service, more to imitate what would happen if you were out in your community church.
Yeah, no, I think that is a general finding in the social support literature, that that the health benefits of offering support to others are equal or greater than the receiving support from others. Getting back to the earlier conversation about needing support, being in times of crisis and vulnerability. So that it gets messed up with that. But being able to offer support to others is really an important thing. That always is a strong finding in surveys. And so I think that, like regular community worship services, are just full of opportunities to serve others, and every bulletin I've ever seen lists all the ways you can sign up for committees to do this, and this, and you couldn't possibly do all of them, but yeah, the opportunities for serving others in the congregation, in the wider community, in the nation as a whole, and in the wide world, all of those opportunities for service are presented. So it makes it easy to find those kind of important opportunities. But I think the idea of thinking about that intentionally in the nursing home services is a great way to have people benefit and to feel a sense of their own skills and their own, you know, competencies. And not that many people can play the organ. So if you've got somebody who can, that's great. But you know but yes, there's finding ways to serve and opening up opportunities for, I don't know, quilting or other kinds of, you know, things that people do in groups would be, I don't know, great. Be creative with it. I think that's a great idea.
I see we hit the 1 o'clock hour. I do have one more question, but do we have time for that?
Absolutely.
So gerontology, I'm so glad to hear that. So gerontology studies indicate that some older adults and middle-aged adults return to or begin to attend a religious congregation at important developmental milestones. For example, sometimes when they have children, they want their children to be growing up in that environment, or even sometimes after they become empty nesters. And I'm really curious about that finding, particularly in this context of secularization, that even in secularization, there's a bit of this increase. So I'm curious if religious attendance is more effective as a protective effect if it's been a lifelong practice, or if it has some equal benefits for someone who's just been attending a few years.
Oh, that's a great question. And it really goes back to the circumstances of our birth, doesn't it? Because people are born into families that do or do not have a religious home. And so a couple weeks ago in my class, and then we're in the Journal Club next week, we're going to talk about a really interesting study that was done in Italy in the pandemic. And they were asking Italians where you know, the early stages of the pandemic were very bad in northern Italy, especially. So things got locked down very tightly there, and religious worship services did go online. I understand the Pope, you know, like was broadcasting, so everybody got to see the Pope do the services on Sunday morning. But that the surveys asked whether people were attending religious services online or not, and surprisingly large numbers of them were. And then they asked how if they had religious socialization as a child, and so it was a very much more pronounced turn to religious services during the pandemic if people had had religious socialization as a child. It was really interesting. So yeah, it seems as if that one can return to childhood experiences with some degree of familiarity and feeling of belonging, but that makes you wonder when there isn't that memory, where, you know, how do people start that fresh in adulthood?
Yeah, that's fascinating. Well, I am aware of time. Sarah, do you have a last word for us?
No, just to once again, Ellen, thank you so much. It was a privilege to hear you speak again. I know everyone got a lot from the words you shared, so thank you.
No, you're very welcome, and it was a pleasure to be here.
Thank you.
Thank you.
Thanks, Ellen. Thanks, everybody.